as well, because to do the procedures that Bob went over yesterday, you pretty much have to do a cystoscopy procedure, so it's kind of repetitive, but we'll just kind of go, if there's any questions, raise your hand, yell out loud, whatever you want to do. So we're going to go over...
what procedures did Bob go over yesterday?
You should have been here yesterday.
It's recorded. It's recorded. Oh, okay.
Yeah, he went over all kinds of stuff. I wasn't here. We're gonna go over anatomical overview, physiology, which is the function of the organs. What's a cystoscopy? Reasons we perform cystal procedures, tools of the trade, and then other cystal procedures that are done. So just like Bob's drawing here, we have the anatomy of the urology system here. We have both kidneys, the ureters, which go into the urinary bladder, and then the urethra where your urine is excreted from. So, and then these are just the major vessels in your body. So the kidneys lie on each side of your spine. They kind of lay back like this. So they're very small. They're about 4 inches long in a human being. We were talking about animals earlier. Pigs have similar anatomy to humans, so they're about 4 inches in a pig as well. They lay on both sides of the spine, like I said. They excrete waste. A very important function of your kidneys is to regulate your blood pressure. They also secrete hormones, and they reabsorb vital nutrients, and then they get rid of the waste. The collecting system of the kidney, this is the upper pole or upper calyx, middle calyx, lower calyx. Where the urine comes into the kidney there, that's the UPJ, ureteropelvic junction. So the ureters are muscular tubes, are about 12 inches long. Obviously, as you're an infant, they're smaller, and as you grow, they get bigger. If you're a taller person, you're going to have a taller ureters than somebody else. They're shorter. They're 3 to 4 millimeters in diameter. So this is about 6 millimeters in diameter, to give you any idea. So they're smaller than this. They can be dilated when you put things up there, but tiny. The ureters transport urine from the kidneys and all that waste into your bladder to be excreted. Urinary bladder, we all know what our bladder is. It's a muscular organ that holds urine, and when you feel the urge, you urinate. So it's just a holding container for that.
How big is it?
How big is it?
Yeah. If the kidneys are 4 inches, how big is the bladder?
Everybody has a different size bladder.
Mine's not big enough.
Johnny's a bigger one. I don't know, Nancy. That's a good question. I could look how many cc's a bladder typically holds, but like I said, everybody's different. The urethra is a tube that leads from your bladder to the outside of your body. Males have a longer urethra than females. Cystoscopy procedures. So reasons they do cysto procedures is to diagnose urinary tract diseases, cancer, bladder problems, diseases, enlarged prostates, blood in your urine. It could be any reason. If you're having any urinary tract problems, they'll most likely run you through a course of antibiotics, and then if that doesn't clear it up, they'll do a cystoscopy procedure. And basically the procedure is where they go in there with a scope, and we could pass some scopes around, and they'll look inside of your bladder to see what's going on in there. Now the scopes that they use, it's just a lens, and it's attached to this is a sheath, so this is used to introduce the lens into your bladder. So what they do is they put this inside of your urethra, and then they pull the sheath out, and they'll stick a bridge in there. So this is inside of your bladder, okay, and then they'll use a lens to look inside of there. And there's light because it's dark in there, so they'll attach a light cord to it. This goes on here, and it's attached to a lamp. And then they'll also have water in there because if you go in there and it's really cloudy, you can't see, so they'll put water continuously through there so you're able to see. So if you want to pass this around, you can take a look. And this is another lens that they use. And you could hold it up to the light and look in it. And that's how they do that. So that's how they introduce the cystoscope in there, and then from there they can do multiple other procedures like Bob went over yesterday with the stent placement. They could put a wire up, they could do a basket extraction, they could do laser procedures, dilations of the ureters. Now urethral dilation, that question was brought up last week to me. What's the difference between urethral dilation and ureteral dilation? Well, your ureters are up here and your urethra is down here. So in order to get in and access the urinary tract, urethral dilation is needed, and they use a device called a sound. It's a metal, basically what it is a metal bar, and they increase in size. So they'll just keep putting them in your urethra until they can pass the scope into there.
How is it considered sound if it's just like a metal piece?
That's what they call them.
Oh, okay.
Yeah, I don't, probably the guy's name who made it or something. I don't know.
Musical notes.
And then a ureteral dilation is when they actually access the bladder and they need to get up into the ureter. I'm not sure if Bob had a balloon yesterday, but yeah, they stick that up in the ureter and then they pump it up and it dilates or makes bigger the ureter. So this is a flexible scope, cystoscope. It's the same, serves the same purpose as a rigid scope, but it's a little bit easier for doctors to do. Instead of putting the patient up in stirrups, you could actually access the patient just laying supine or laying on their back. And it's the same thing. They have a hookup for water and a hookup for light. And if you move that around, this back and forth, it actually angles the tip there. So you can get up and find where the hole in the bladder where the ureter comes in to put your wire up. Now flexible, they also have flexible ureteroscopes, which are about the diameter of this. So it's the same scope like that, but it's this small. And they could actually pass that all the way up your ureter and look into your kidneys. And they can do laser procedures like holmium lasers to break up stones up there.
Someone pass it right down for 10.
This, like that.
So cool.
That plugs into the light source.
Yeah.
Yep, that's the light.
So do more doctors prefer the rigid or the flexible?
It really depends.
Out there?
Depends on what they're doing.
Okay, so they kind of sometimes
Most
use
of them
both.
go with a rigid first. If it's just a stent removal, some guys like during a lithotripsy with a couple hundred shocks to go, they'll stick a flexible in, find the end of the stent, and use graspers, which have little grabbers on there, and they'll just grab the stent and pull it out, and then we're done all at once. Instead of pulling the patient down, putting them in stirrups, I mean, it just saves a lot of time.
Okay.
And some physicians are more skilled than others.
So flexible, you don't have to really get them with their legs up, or is that what you're saying?
No, flexible you really don't have to.
Oh, okay.
Do we bring these to the mobile sites?
Some of the places we still bring these, like Rockford's office, and we do these procedures with the physician. So our patient care techs scrub in with the urologist and they'll hold the wire. The wires get really slippery, so when they put a wire in, we need water. So we get a cup of water. Kind of gross if I spit on it. So, when they put this wire up, it goes all the way up into your kidney. And then there's this much sticking out of the back, and you know, everyone's sterile, they have sterile gowns on, you don't want this touching the floor or anything else. So they actually have an assistant with sterile gloves on, or patient care techs, or a scrub tech in a hospital, and they'll hold the back end of the wire so it doesn't flop around. So the doctor has the scope, and he's manipulating the wire, and he gets it where he wants it. Then he'll tell the scrub tech, okay, you can put the stent on now, or you could put on the catheter, and it's that person's job to do this while it's in there, because if you pull back, you'll pull it out of place. So the x-ray tech makes sure it's placed in the kidney the whole time and it's not pulled out using x-ray. And the scrub tech's job is to feed this over that without pulling it or dropping it, and then holding the wire, and then the doctor will take it from there and push it in and do the rest of the work. Some things that are done in conjunction with cysto is stent removal, stent placement, ureteroscopies. Retrogrades, sometimes there's stones and they can't see where the stones are at. So what they want to do is inject contrast in there, and they would use a catheter like this. Or you can pass this around. Feel how tacky the wire is, and then dip it in the water and feel how slippery it is. You can just, yeah. So imagine trying to hold on to that. It's kind of crazy. It's so hard to, and then the doctor yells at you when you're slipping all over. It's kind of. So they can do BPH procedures, stone manipulations. I was talking about the retrogrades. Sometimes they can't see where the stone is at on x-ray because there's radiolucent stones. That means they can't be seen by x-ray. So what they do is they inject a contrast medium in there, and that contrast is dark, and the stone shows up white. So you could actually see the stone because everything in here will be black. With the exception of the stone, it'll be a big white spot, and that's what we end up treating with lithotripsy or with holmium laser. There are different color stones, and actually different shapes, sizes, and different compositions of stone. So a uric acid stone does not show up on x-ray, so that's one that you would need contrast for. There's some real dark, gross looking stones like blackish and yellow. And then there's some just white stones, some with jagged edges, some smooth. The smooth ones are actually harder to break than the ones with jagged edges. And lithotripsy, what lithotripsy does is when we administer the shock, that compression wave goes through the stone. It hits the back of the stone and refracts back through the stone, and that wave going through and coming back actually shakes that stone apart.
Dip it in the water.
So,
How much more slippery it is.
Or sometimes you do social capital.
Dip it in the water.
so you have to insert a catheter to do a retrograde.
So if you insert it in red and white, sometimes you do, sometimes.
Sometimes you do it, sometimes you don't. Sometimes they'll put a catheter in just to push a stone into a different, like that would be with manipulation. So they'll put the catheter in to push that stone where they want it, so they don't inject contrast. So they'll push that stone up. Sorry, you just can't see. And they try and work it, and they'll push it until they get it in the kidney. And the reason they'll push a stone up out of the ureter into the kidney is because there's more room in the kidney for that stone to expand when you shock it. If you shock it where it is, there's no room for it to go in there. Where's it gonna go? You know, that muscle, that ureter is a muscle and it holds it tight. So there's really no room for it to expand besides up and down. So you get a way better treatment if you can put it in here where when you break it up, it can expand all.
I have a question for retrograde.
Yes?
Most of the time they use catheter, but how about injectable stent?
Yeah, injectable stents, they're not used, in my opinion, as much as they should be. Because what a doctor will do is they'll stick a catheter up and a stent up. And it could be done with they don't teach it at institutions as much as they should at teaching institutions. Because they like the repetitiveness of going up with a catheter, going up, you know, doing things like that, instead of getting it done in one shot. And an injectable stent is a stent, just like a regular stent. I tried this one. It's a stent like this. And in the back end of the stent that goes into the bladder, you could actually attach a catheter. And then the stent has more holes up top, and what they do is they stick a syringe on this.
How you attach?
Huh? This is not an injectable. Pretend it is. Use your imagination. So it would attach like this, and then you would inject your contrast through here, and then when you're done, you would just pull that off.
So why wouldn't more doctors use the injectable stent?
They're not familiar with it.
Okay.
There's only one manufacturer that really perfected it, and it's Cook.
Mm-hmm.
And most of the hospitals don't even use Cook stents. I mean, the best stents out there are microvasive, Boston Scientific stents.
Okay.
So
Because it's
the
rare
reason-
that we see the injectable.
Yeah, we only have them at our fixed sites now. We don't carry them on the mobile anymore.
Okay.
So the reason when it's injectable stent is for the retrograde, right?
You could use a catheter.
No,
For
but when you
retrograde.
use injectable stent.
No, when you use an injectable stent, you can't really do a retrograde with an injectable stent.
You're
cannot do
injecting
it?
contrast
You're-
or what, the IVP or?
Yeah, you're injecting contrast through the stent, but it's really not a retrograde. A retrograde would be a catheter because you're going back up. When you're injecting through a stent, you're injecting it into the kidney and it's coming down. So, really coding wise, it's really not a retrograde. A retrograde is with a catheter going against the flow.
So it's a different type of contrast? Is that what we're saying?
It's the same contrast.
Same contrast, okay.
Yeah, but a retrograde means going opposite of the way the normal flow is.
Okay.
So it would be a catheter that they would use to do a retrograde, going up.
Yeah. What happens if, let's say the patient needs to come in for stent removal? What happens if they don't? Does it dissolve or is it harmful?
No, actually it's really bad if a patient doesn't come in for a stent removal. They can become septic and die.
Oh, wow.
So stents, at the longest they should stay in is 6 months, and that's extreme cases. Usually they change them out. Pregnant women, there's a lot of things you can't do. Sometimes the stones are too big, and you can't do lithotripsy. So what they'll do is put a stent in until the patient has their baby, and then they'll go in and treat them, because they don't want any complications with anesthesia. They don't, it could be a local procedure. So what they'll do is they'll put stents in and switch them out. Now, if you leave a stent in too long, some patients, we see it a lot, they're non-compliant. They put a stent in, they treat the stone, next thing you know, a year later, they're coming back in the emergency room just on death's door. They're sick, because they never went back to have their stent taken out. And what'll happen is, if they've had stones before, that stent will calcify in their whole tract. So it'll be in here, and it'll be stones from here all the way down into there. And if this doctor tries to pull the stent out, what happens a lot of times is it'll snap in half. And you'll only get the bottom part out, and then they have to go up surgically and remove it. Now, sometimes we could treat them along the whole stent with shockwave just to break enough stone away, but it very rarely works because there's so much stone at the circle part of it that's in the kidney up there. You just can't get enough of it away. So they actually have to go in through your back, a percutaneous. They'll cut you open. First, they'll stick a needle in your back, and then through that needle, they'll stick a wire, just the same type of wire, to get access to your renal pelvis. And then through that, they'll stick another catheter in, and then they'll go through that, and they'll break up the stones either with a laser, EHL, different ways. But then you'll have a big tube in your back because you'll have a drainage tube to drain your urine until your urinary tract clears. And sometimes they could clear it from the top, going down, get the stones out, kind of meet in the middle. So you'll have a systole and a perc.
Then they may go into the next time for the doctor when they need
They
to.
can, yeah, they can laser from the top down. It's the same principle as going up. I mean, they have a scope and they can feed the wire down. And anything you can do with the wire, you can do with a laser probe. Questions?
What type of laser would we use for that one?
The Holmium laser.
The Holmium?
Yep.
I got a question. What is it when we see it say staghorn?
A staghorn is a stone that comprises the whole collecting system of the kidney.
So it's one stone, or is it like a bunch of stones?
It could be a couple stones, but it's typically one massive stone that fills this whole area up.
Oh, wow.
And they usually do perks for those.
Okay.
Some patients don't want to be cut open, or so they'll opt for 4 or 5 as well treatments. Yeah.
Uh-huh. Huh.
Yeah. And if you, as a tech, if you bite off more than you could chew, and just like center in the middle and just hammer it, you have bigger problems, because then there's big pieces of stone everywhere. So you're better off focusing on the UPJ area and treating 3,000 shocks here, and then because you got to think long term, big picture. You can't just, you're not going to get it all in one treatment. So you should start small and then work on the upper pole the next time the patient comes, because the flow's like this. If you start down here, it's not going to do anything. You're just, you know, I mean, the way the kidneys are shaped, your lower pole, even if it's one tiny stone in your lower pole, you have trouble flushing it out because your kidneys are like this, and we're always upright. You know, urine just flows out. I mean, unless you stand on your head all day, you're not going to get that out. And there is a thing called inversion therapy where they tell you, you know, if you have lower pole stones, drink plenty of fluid and then lay inverted to flush that out. Well, we had a professional in our field, no names, he thought he would do himself a favor, and he was treated, and he did inversion therapy on his own, and he ended up in a hospital for a stent because all that stuff that was treated all came out at once and got stuck in his ureter. So, so
Wow.
not a big fan of inversion therapy.
So how many,
What is the limit of shocks somebody can have, and what length of time between multiple treatments should somebody wait?
Well, you should wait 2 weeks between treatment because it does damage the tissue in the kidneys. There's some studies out there that say that it actually causes hypertension. It's not proven yet, but the number of shocks is based on the number of machine, the type of machine. So the machine is FDA approved for a certain number of shocks. Most of them are right around 3,000. Now the shocks can be distributed at a different rate. They're saying that a slower rate is breaking stones better. Questionable, you know, I mean, it could, I don't know. So we basically treat at 120 shocks a minute, so 2 per second. Some doctors like going slow, and that's why you'll see treatment times are different. Usually treatment times are about 25 minutes for us, but you'll see some are double that time, and that's because the doctor's going slow shock.
Sometimes we go 1 kidney and next week for another. Isn't it easy to
They don't really like doing bilateral procedures, and the reason why is because you can get something called a hematoma, which is a huge bruise, okay? So if you treat this with lithotripsy, the left side, and you get a hematoma, you'll be bleeding, and you might need a transfusion, and you could actually lose your kidney. It's a possibility. It's very rarely that it happens, but it could happen. So if that happens, and they treat both kidneys, and it happens to both sides, you're not going to have any kidneys. You'll be on dialysis the rest of your life, every day. If they treat one kidney, then at least you could live with one functioning kidney. So that's why we try to recommend that you don't have bilateral procedures.
Now, Al, at the mobile sites, you don't no longer bring supplies besides this actual chromium fibers or XPS fibers.
We do at the Rockford office. We still bring stents, wires, scopes, contrast, everything.
That's one of the only locations.
We still bring them to other locations that we're trying to clear up because the contract doesn't call for it, but we've always brought them there. And when we tried not bringing them there, like Morris is one of them. We still bring stuff there. Elgin, Sherman, Condell, we're trying to work through that one now. All the hospitals have wire stents.
So why do they prefer us to bring them if they have them?
Money?
Just,
Money.
You mentioned the hematoma, so why would the doctor determine that he would do it bilateral? Like, what would be would there be a health, like a healthy person, they would determine that I can go ahead
You know,
and do
even
that?
healthy people
Can develop the
can get hematomas. Actually, if you did a CAT scan after every lithotripsy, every single patient who had a lithotripsy would have a hematoma of some,
Sort,
degree. It
right.
could be a tiny one, but they would have some because the tissue just gets bruised and it bleeds. So what would prompt the doctor to do a bilateral? Could be small stones, maybe one on each side where you're not going to go to 3,000 shocks. He might put a stent in both sides and treat it. It just depends on the physician. Most of them don't treat huge stones on both sides. I don't think I've ever seen it. Maybe a huge stone on one side and then a tiny one on the other side, just so it doesn't become a problem. Because if you leave a stone in there, it's going to become a problem eventually. Nancy,
Is lithotripsy still the gold standard for treating stones?
it depends on the physician. It really is, and it depends on the location of the stone. So if you have a stone down here, your pelvic bones cover this whole area down here. And really, John covered areas is not good for business, but if a doctor wants to do a lithotripsy down here, the best thing for the patient is to do a ureteroscopy. I had a case a couple weeks ago in Michigan City, and the physician asked me, the stone was over the pelvic, right where the vessels go, because your vessels come right here, so your ureter goes over that. It's a very difficult spot to access, and this physician couldn't access it, had lots of problems. The patient came into the emergency room, was septic, really sick, and the physician asked, so what do you think? Ureteroscopy is the way to go there. So that's what she ended up doing. She did a holmium laser, she got it all out, and that's what we're here for. We're here for the patients, we're here for the doctors, and that goodwill goes a long way to more procedures in the long run. It's good that lithotripsy does us well, but it does us better to treat every patient like they're our mother, father, brother, anyone else.
I got a question.
Yes, Dana.
Ureteroscopies are done a lot at the fixed sites. So what about on mobile? Not necessarily with the laser,
So
is
you-
this our
so-
ureteroscopy?
You won't see, we don't bring ureteroscopes on the road.
So if they mark it, it's the hospital?
It's the hospitals.
Okay.
Yep. And you'll see ureteroscopies, every holmium case, almost every holmium case, 80% of them are probably ureteroscopies.
Okay.
They'll do some holmium cases for bladder stones where there's a huge stone in your bladder, and they'll break that stone up with a holmium laser.
Okay.
But we don't carry ureteroscopes.
For the mobile? Okay.
Even to like Rockford or
No.
anything else?
It's a really risky procedure to do in an office-based setting. They do them, but if you perforate the ureter, which is easy to do with a rigid ureteroscope because you're sticking a piece of metal in a tiny tube and you're trying to poke a wire through, if you could sever that ureter, and then what they have to do is go to surgery, and they have microscopes and they have to sew it back together. So they have to open you up to do that.
How often would something like that
You're talking
happen?
about ureters. You're talking about ureters now.
Ureteroscopy.
Because holmium we're doing everywhere.
Yep, holmiums we do, but we don't bring the scopes. We don't bring ureter scopes for that, for the holmiums.
How often does that happen, like if they perforate?
It could happen quite a bit. Actually, almost every ureteroscopy has some type of perforation of the ureter. It could be just a wire poking through,
Mm-hmm.
because you always have to have access to the kidney, so you always have to have a wire in for a ureteroscopy. So you'll see, as an X-ray tech, you'll be forward, and then you'll see the wire go like this. You're like, oops, there goes one. And it's just a little pinhole, and it heals itself.
Okay.
so they don't need, yeah, you just kind of look away. And then you can see, because then they inject contrast, and then the body's filling over contrast instead of it staying in the collecting system. Anything else? Roxana?
Oh, go ahead.
No, go ahead.
I have a question. This is just logistically. How many pieces of instruments is the physician holding at the same time to maneuver through the procedure?
Usually they're all set up on a back table, so they're just pretty much holding the scope.
And then working through.
And the assistant, scrub tech, and they'll hold the wire and hand them the other things.
Okay, so it's not like they're balancing.
No, no,
Circus.
But a lot of stuff hooks to that scope,
Right.
right?
it does.
The water hooks to it.
It does, so like a wire, what they'll do if they need the scrub tech to get something else, and it, scrub tech's like, well, so what they'll do is they'll take hemostats and pinch it to the drape, and then the scrub tech can get something else. So they have ways to work around only having two hands.
Multitask.
So for Homeo on the mobile side, they use the ureteroscope of the facility
Yes.
to get the laser,
Yes.
because it has to be fitted, that fiber, which look like a wire. I was surprised to see, because we didn't see, I mean, also for me, I saw it yesterday, how it looks like Homeo fiber. I know they were flexible, They
It's
have
just
the
like the
laser.
wire, yep.
So they have to fit it to the, ureteroscope.
So when we go on a mobile basis to do homium lasers, the hospital has all the scopes, everything. We bring the homium machine and the fiber. And the doctor will access the uriner, and then they'll say, okay, let's open a 365 fiber, and we'll give it to the nurse and she'll open it. And then they'll put it up, and we'll attach it to our machine, and we'll choose the settings that we need, depends on the stone and where it's at. And then the doctor will step on the pedal to break the stone up. And he's looking at it the whole time. A lot of times they use a video screen, so there's a camera system that fits on the back of the scope, and it's on the big screen TV, so everyone in the room can watch it. The younger guys love it because that's how they're trained. A lot of the older guys never use a camera. They're still down and dirty and dirty. Don't know why you'd want your head down there. Watch it on TV. But they do. They like it.
How does the doctor determine the type of the fiber that he wants to use?
So the size of the homium fiber it's basically flexibility. So a 200, a smaller, a 150 or 200 micron fiber has the flexibility to go up and make bends, like if you're treating lower pole stones. As you get higher in number, like a 1,000, there's no way you'll ever get a 1,000 up that high. It's thicker, it's harder.
More rigid.
So that it's more rigid, so they use those, and you can put more energy through a 1,000 because it's bigger and more robust. So they use those for bladder stone. So basically it's like 1,000, 550, 365s, 200s, or 150s.
Okay.